deepen solidarity within our family of trade unions. We campaign for well-founded public services and better rights at work. Our vision is a Europe with public services at its core. Good jobs in our sector means quality services for citizens. Our members know that the services they deliver are not a cost to society, but an investment in our community. We think that message to the heart of Europe. The European Union has made social dialogue to one of the main pillars of EU as recognized in the treaty. In many statements and communication, and most recently, for example, in the European Pillar of Social Rights. Thus, for EPSU, the social agenda and the social dimension in all policy is a permanent concern in all 5 EU sectoral social dialogue committee: hospitals, electricity, gas, local and regional government, national and EU governments. Given EPSU's involvement in health and social services committee and the impact of COVID-19 pandemic on the health of European health and social care workers, we consider opportunity to collectively reflect on how to support our staff for 2 different perspectives, a more academic and scientific one, as well as one of the practice and the field observation that our affiliates are experiencing in the hospital since the beginning of the outbreak. Supporting the mental health of medical staff and affiliated healthcare and social care worker staff, it's a critical part of the public health response. The extreme challenge that will be faced by frontline workers in the coming weeks and months means that the psychological science and the action from the union organizing staff in the hospital has an important role to play in supporting their staff performance and health. And from now, I invite my co-chair, Mr. Julian Bizold, Secretary General of the European Federation of Psychologists Association, to continue.
So thank you very much, Razvan. Good morning, everyone, and welcome to this webinar, which is first, I think, for many of us, especially a first as a collaboration between EPSU and the EPA. So I'm just going to start off first to say a huge thank you to people from EPSU, Razvan, and all the colleagues in the office, and also to the people from EPA in the office in Brussels, Marie and Laura, for the work in making this possible. Introducing myself, I'm a psychiatrist and I am the Secretary General of the European Psychiatric Association. I work in a day job in a general hospital in England, providing mental health services to people in the hospital. Many of whom currently have COVID. My role within the European Psychiatric Association, so this is an association comprising psychiatrists across Europe. We have individual members, but we also have members in the form of the national associations of psychiatrists in 40 different countries across Europe. And altogether, we represent something like 80,000 psychiatrists right across Europe, European Union and beyond. The purposes of the EPA is really to promote high quality mental health care in Europe for people. And we do this in a number of different ways. In terms of activities, we have annual congress and other scientific meetings. We have a journal called European Psychiatry, which we're very pleased you'll meet the editor of this shortly. We run a number of courses on scientific topics. And very importantly, we are collaborating with a wide range of other organizations across Europe with a shared interest in promoting good quality mental health care. One of the things I wanted to emphasize is our collaborative approach. And that, I think, is evidenced, for example, by on our board, which controls the EPA activities. We have the organization Gamian and Eupharmi, who respectively represent people who suffer from mental health problems and the families and carers of people who have mental health problems across Europe. So they are full voting members of our board, emphasizing the importance of this collaborative aspect of trying to improve healthcare for people with mental health problems. So I think that's enough in terms of us. We want to move on to the main program, which is what you've all come for. And the first speaker, it's my pleasure to introduce, is Professor Andrea Fiorillo. He's one of the editors of European Psychiatry, our journal, and has also been a board member of the European Psychiatric Association for a number of years. And he is going to do a short presentation on the consequences of COVID-19 pandemic on mental health, and importantly, the implications for clinical practice. Professor Fiorillo.
Julian, sorry, before giving the floor to Mr. Fiorillo, hi everyone. I'm Luca, one of the organizers. I wanted just to introduce you a second Q&A button that you can use in order to make questions. As you can see on your upper bar, you can see a strange button called Q&A. This is the way how you can make questions. We will collect them and we will either answer live or giving you an answer in written. So if you have any question, don't hesitate to use it, to open it and to write your question, and we will make sure we can answer to them. Thanks, and please.
Thank you very much.
Okay, so thank you very much, Julian and Razvan, for your kind introduction, and also thanks Luca and all people at EPSU for inviting me to join in this webinar and to give me the opportunities to talk about the consequences of the COVID-19 pandemic on mental health and what are the implications for clinical practice. Let me start this presentation by introducing you this paper which we published, myself and Philip Gorwood, who is actually the chair and president of the European Psychiatric Association, just when the pandemic started. So at the beginning of March in Europe. And I would tell you that Italy and France have been one of the two of the European countries which have been mostly affected by the pandemic. And this is why we decided to write this editorial, where we stated that according to what was the situation in our own countries and also what happened in China, there were already consensus that the pandemic does not only affect physical health, but also the mental health and well-being of the general population. And that this pandemic will change priorities of psychiatrists and other mental health professionals working in the public and also in the private sector. But this was true because the pandemic of COVID-19 on mental health come from different sources. Many people following the lockdown are affording difficulties from an economic viewpoint. There is an increased stress of working from home, basically without office hours. Basically, everyone is always online every day and every hour of the day. Many of our patients had to interrupt their treatments because they couldn't come to the hospital or because they were scared of getting the infection. Also, there have been other problems in the families because schools and college were closed. Many people are living in a period of social exclusion and also bereavement. In some countries, there has been a lack of access to food. Also, we have seen an increase in domestic violence and, as already told you, the fear of infection and of contamination. But these inequalities are most likely to influence some groups of the population. in particularly those who are unemployed with low income, or those who live in the private areas. But also some diversity can be found as regards age, or sex, or race, or religion, or sexual orientation, or disability, and so on and so forth. Also, differences can be due on the place of living, if someone lives in urbanized areas or rural areas. And then again, the problem with homeless people that has already been stated by many health authorities. So the economic and social responses to COVID-19 has the potential to exacerbate these already existing health inequalities. And the rapid transmission of COVID-19, basically our life has changed from one day to another, but also the high rate of fatalities in some populations, the lack of effective treatments, and also the measures of quarantine have led to an increase of common mental health problems, including an increase of fears, anxiety, depression, and particularly sleep problems in not only in people with the COVID-19 infection, but also in their family members, also in the general public and in healthcare professionals. But besides these, there are also new psychiatric symptoms in these individuals who are experiencing stress, anxiety, or grief. Also, we have to state that some people are experiencing losses under traumatic circumstances, for example, not being able to say goodbye, or also the inability to offer proper burials to dying loved ones. And all this is generating new symptoms for which we are not equipped yet, and for which mental health services are still trying to find a way to overcome all of these problems. And we have subdivided the impact on mental health of the COVID-19 in three different domains: that of distress, that of risky behaviors, and that of proper mental health disorders. Now, of course, as regards the first group, that of distress reactions, here we can see problems which are common to the general population, including insomnia, anger, fear of the illness, even in those who have not been exposed to the illness. And this is why, with Philip, we anticipated that the effects on mental health would have been different in the four groups of people. Basically, those who have been severely traumatized, including people who have been directly or indirectly exposed to the virus, those who are already vulnerable, including disabled people, including the people with already difficulties, but also including people with mental health problems. And then the third group is represented by the general population, people who have been quarantined during these months but have not been isolated, so meaning that they have not been directly exposed to contagion. And the fourth group is that of healthcare professionals, which has been divided in two groups, the first and second line of professionals. So let's see what were the main distress reactions for general population. The fears of falling ill or dying, the fear of not being able to work or to be dismissed from work, the fear of being socially excluded, the fear of not being able to take care of loved ones, but also other psychological reactions such as helplessness, boredom, loneliness, and also feeling of depression. But what is more important here is that physical distancing can generate difficulties in the general population. Of course, physical distancing is essential for flattening the diffusion of the virus, but the last thing that our fragmented world needs is social distance. So as a society, we may come out ahead of this epidemic if we pursue physical distancing, but keep social connectedness. And Danuta Wasserman, who is the chair of the Committee on Ethics of the European Psychiatric Association, has just published a letter in Science stating the importance to use the right words, and therefore physical distancing is much better than social distancing. But as regards psychiatric symptoms, we are already witnessing, both in China and in European countries, an increase of many psychiatric disorders. For example, the overall prevalence of the generalized anxiety disorders is 35.1%, while the prevalence of depressive symptoms is 20.1%, while usually the prevalence of depression is 7% in the general population. There is a mild to severe psychological distress in about 20% of the general population. And also the occurrence of anxiety and or depression is associated with the time spent on searching for COVID-19 related news. And this is extremely important because we want to fight the fake news, which has caused what now is called infodemic, this request to search for news on internet or on magazines or on journals, but in many cases these news are not controlled. Another problem that we have seen is the increased use of alcohol or drugs. For example, in Belgium and in the United Kingdom, we have seen an increase of alcohol sales from 10 to 20%. And the other problem belongs to the area of post-traumatic stress symptoms, which has more or less 7% of the general population, while also in previous epidemics, such as SARS-1, it was 3.7%. So again, this situation is causing very serious problems to the general population, to patients. We are already suffering from mental health problems. For example, on loneliness, we know that loneliness is a serious risk factor in precipitating some psychiatric symptoms in people who are affected by different mental disorders. Also, we have seen that in patients who had already been diagnosed with any mental illness, there is an increase in worries and also an increase in suicidal ideation. And also that more than 30% of our own patients fulfill the PTSD criteria following the COVID-19 pandemic, that insomnia is present in more than 25% of patients, but also we are seeing an increased number of symptoms of obsessive compulsive disorders. And let me talk just a couple of minutes about the increased risk of suicide, because this is strongly related to the objective social isolation, but also to the subjective feelings of loneliness. Now, here we should distinguish between those who have a mental illness or had already had a suicidal crisis in the past. And for these people, we need targeted, selective, and indicated interventions. And this, of course, would include a clear assessment, but also the introduction of helplines and also political resources. But then we have another problem, which is coming out now, that of the general population who are not mentally ill, who have not experienced previously suicidal ideation, who are now actually increasing their thoughts about suicide due to the financial stressors, due to the increase of domestic violence, due to the increase of alcohol use, but also to the use of isolation, loneliness, bereavement, and particularly to the irresponsible media reporting. So I think that for this situations, for these people, universal preventive interventions are needed. And these include several strategies, including provide financial safety nets from the government, including the reduction of alcohol use, including the importance to communicate with friends and family members, including also to moderate the media reporting about the COVID-19. And the fourth group that I think will need our help is that of healthcare providers, because they themselves may develop psychiatric symptoms after coping with this situation. And in fact, in the current situation, about 30% of our healthcare workers working in the first line are reporting psychiatric symptoms, which are not different from those found in the other groups. And those symptoms seem to be more severe in female workers. And we have to know that healthcare workers cannot be urgently manufactured or run at 100% occupancy for long periods. We have already asked them too much. They are not ventilators that can be manufactured from one day to another, and that their safety must be ensured through practical measures, which may include also psychological support, but also other means of support. In Italy, we have run this study. It's a multicentric study which has been run now in more than 10 Italian cities, and we have published already this study, and also it is still online. This is the website, and also it has been covered by media. And actually, in this study, we had included about 20,000 people, and they have been subdivided into 4 groups. COVID plus traumatized patients, mental health patients, healthcare professionals, and also the general population, which is obviously the higher number of people. And what I can tell you that, I mean, we don't have still the final data, but up to now, so in this general population, we have seen that about half of them are feeling moderate to severe levels of stress. That 30% of the general population has feelings, moderate or severe feelings of anxiety, that about 27% have depression, insomnia, severe insomnia is present in less than 10% of people. But I think that the most important and striking finding up to now is that 15% of the general population has suicide ideation. All this will include a new model of care, and this is the second part of my presentation, dealing with our possibilities to respond to this crisis. Actually, we have seen that during the first days of the pandemic, so March and April, most patients preferred not to attend control and emergency visits. This is taken from a study in pediatric emergency departments, where the authors found that in 2020, in Orange, in March 2020, the number of access for pediatric emergency visits was steadily decreased compared to the same month of the previous 2 years, 19 and 18. But also, if we consider the rate of hospital admission for acute coronary syndromes, is steadily decreased in just a month. But then we are expecting, and it's actually already happening in our country, an increased request for psychiatric consultations. This is why we believe that there is the need to establish appropriate mental health services to address the risk of psychiatric morbidity, but also that mental health professionals now are facing very difficult challenges because they are due to the lack of relevant guidelines, to scant mental health resources, and also to an inadequate training. And although this, Tedros Ghebreyesus, who is the Director General of the World Health Organization, in this editorial, which has been published in the last issue of World Psychiatry, which is going to be published actually in June this year, so it is not fully published yet. One in this editorial is stated loudly that there is the need to strengthen mental health care in countries recovering from COVID-19. And how we can do that? Where this is some advices following professional organizations, adhering to the policies of the governments, reorganizing mental health services and activities, using telemental health, addressing the mental health needs of the general population, having a long-term planning for care, and also investing in mental health works. And of course, I cannot go into detail all of these strategies, but just I will give you some examples. Julian Bezold already stated about the EPA, the European Psychiatric Associations. We have launched a COVID-19 Resource Center where you will find all information from several countries and also with the practical advices on the management of difficult situations. But also in the European Psychiatry, the official journal, we have a COVID-19 Resources and Information Center where all papers published in good journals, actually including our editorial, can be freely downloaded by anyone in order to know how to interact with the COVID-19. Also, the reorganization of mental health activities have started from the fact that from one day to another, we had to change our clinical programs. And in Italy, we have never closed the activities for mentally ill patients. So now we have to do something different from we did until February this year. So just in a few months, our life and our professional life has significantly changed. Now we have to organize screening procedures for all new patients, meaning that our visit now lasts a little bit longer. We have moved most of our visits to telemental health care, basically from 0 to 90%. We have developed the new protocols for patients who are admitted to our inpatient units. We have postponed all non-urgent clinical activities and also group activities in order to guarantee physical distancing. The staff can meet through video calls and every week have to pass surveillance tests. But in response to physical distancing, the telemental health, I believe, is really the future, because this has enabled an expanded access to psychiatric care, whereas face-to-face care would lead to the spread of infection. And this is what we are doing in my own department in Naples. We are addressing the mental health of our patients and of the general population by issuing an helpline. So there is the first contact. Then if someone is suffering from difficulties due to COVID-19, there is a clinical evaluation being made by phone or by video chat. And then if they are screened negative, they receive a psychological support, online psychological support. If they are screened positive with a mild to moderate level, they receive a session of telemental health psychoeducational approach. If they are screened positive with severe level of symptoms, then they are immediately sent for an outpatient face-to-face visit or admission, hospital admission. So I'm going to conclude what we learned from this situation now in Italy. And I would tell you that we have probably faced 3 different phases. At the beginning, we had an initial shock and fear. And at that time, we learned that we really need to take care of our patients, because people with mental ill are tremendously vulnerable compared also to other groups. But that we also need to take care of new patients. And this is just the start of the second phase, who are severely stressed or traumatized by the current crisis. But also that we have to provide support, psychological support and psychiatric support to our healthcare colleagues who are on the front line, who are working since 2 months without any interruption. As also believe that this moment, this difficult moment, offers us the opportunity to advance our understanding of how to provide the prevention focused at the population level and national level psychological first aid and mental health care. And this is why I think that something positive we have learned from this situation, from this difficult situation, which has changed totally our life. And this is also the new ways of coming out from this global emergency. And this is my conclusion, which is taken from the editorial of European Psychiatry. Of course, sooner or later, the pandemic will be over, but its effects on mental health and well-being of the general population, of health professionals and vulnerable people will remain for a long time. Whole mental health community will have very quickly to reorganize its activities in order to take care of all these people in innovative and personalized ways, using, for example, telemedicine. But I think, most importantly, that the time to do it is now. So thank you very much for your attention.
Thank you very much, Professor Fiorello, for that presentation with lots of things to think about there, lots of ideas and lots of reflections on the experience you've already gained. I'd just like to welcome all the people who've joined the webinar since we started. And I'd like to encourage people to use the Q&A button. Most of us will find this at the bottom of our screen to enter questions, type in your questions there. And then at the end of the session, when we have the question and answer, we will deal with all the questions. We will answer them at that point. So I'd like to now welcome the second speaker from the European Psychiatric Association. This is Professor Simavi Vahip, who is a professor of psychiatry in Izmir in Turkey. But he is here speaking in his capacity as the chair of the Council of National Psychiatric Associations within the European Psychiatric Association. So he's the chair of all the national associations of psychiatrists from the 40+ countries that are represented in this body. Simavi, over to you.
Yes, share the screen. Okay, thank you, Julian. First of all, I want to thank EPSU colleagues of all persons who is responsible from this webinar, which I found it very fruitful, efficient, and timely. I think we are going to collaborate in near future very much. So I want to share my thoughts on, sorry. Well, I'm starting, I want to start with a question which probably all know very well. Why did we choose to be healthcare workers? Well, of course, each one of us has a history behind our choice, but simply we want to help people. Today, we are passing through extraordinary days with the COVID-19 pandemic, and there are many patients who need help. In order to be able to help these patients, I think we need three things. We need to protect ourselves and be healthy, both physically and mentally. We have to be a functional part of our teams, and we have to be guided by science, organizations, and previous experiences. There are many updated documents and instruments which cover all kinds of needs and details. So I'll only focus on healthcare workers' mental health and try to give an overview. Protect ourselves and be healthy both physically and mentally. Well, what are we experiencing during the COVID-19 pandemic as healthcare workers?
So
As
Marvi,
Andrea,
can I just ask, are there slides that you are able to share?
well, I am sharing. Let me try once more. Is it okay now?
I don't see slides. I'm not
Don't
sure.
see
If,
slides. Just a second. Is it okay now? No.
I think if it's not possible to get the slides, maybe just carry on with the presentation. And then Marie, is it possible for you to put the slides up yourself, please?
Well, I just 1 second because am I sharing now? No.
I think so, Marvi, please just continue.
Okay. Well, I was mentioning what are we experiencing with COVID-19 pandemic as healthcare workers, and there were many different risk factors influencing each of us. And as you know, risk for infection, risk for transmitting infection to our families, necessity for living far from our families for a long time, expanded workloads, physical exhaustion and burnout, new and unfamiliar clinical roles, enormous increase of facing life and death issues, facing huge amount of critical decisions, shortages of personal protective equipment, shortages of ventilators, ICU beds, stigmatization, and of course, worldwide restrictions, quarantine, economical depression, uncertainty, and many more. Under these circumstances, it is not natural to have many distressing feelings and thoughts. Stigmatization, I am going to give an example of for the stigmatization and discrimination that healthcare workers is being subject to. I was trying to show on my slide a paper page hanged on elevators in the apartment. In the printed part of the page, it was written that in bold, healthcare workers who are living in this apartment, we request them importantly not to touch doors and stair railings. And in the empty places of this paper, a person write with handwritten part responses of the only doctor living in that apartment as the only healthcare worker, many anger and more feelings. So I think we are facing many different kinds of feelings and discriminations and also stigmatizations. I want to mention that from our natural feelings to dysfunctional symptoms and syndromes, first, we may feel fear, anxiety, worry, stress, and irritability, as Andrea mentioned. Additionally, mainly sleep disturbances and alcohol and drug abuse. However, we are sure that these are not signs of weakness and insufficiency, and we have to overcome these feelings, accept and overcome these feelings. We have to organize individual strategies, team members' responsibilities and support. Working with a body model is one of them. Also, there are some responsibilities of administrators' responsibilities. Also, professional support. Each one of these strategies have different importance. First of all, I think we should do something for our physical and mental health individually. It's usually, as all know, eat sufficiently good food, sleep well, rest adequately, avoid social media with negative news, relax during the working hours and after the working hours. Physical activity as much as possible. Avoid tobacco, alcohol, drugs. Continue your contacts, even virtually, family, friends, loved ones. And also, each one of us has different effective strategies in the past to cope with the stress. Probably the best way is to try them again. However, I want to mention the importance of team members and their responsibilities and support. Always, all of us could and should be good observers about changes and needs of our teammates. Additionally, appointing bodies who will remind each other to take a break, eat, or anything else. When we come to administrators' responsibilities, providing all necessary equipment, information, and organization is under the administrator's responsibility. And professional support, when and how, simply whenever you need. Discuss with the psychiatrists, clinical psychologists in your institution and hospital. What can be done for healthcare workers with more dysfunctional symptoms and syndromes? Well, some of us may also experience mental disorders, as Andrea mentioned, either as a relapse of a pre-existing disorder or as a newly start disorder, especially in the vulnerable individuals. Most frequently, anxiety disorders, depression, acute stress disorders, maybe in coming days, PTSD, and somatic symptom disorders. How to overcome? Well, at this point, professional support becomes more important. However, sometimes there could be some obstacles preventing to apply for professional support. Influence of stigmatization towards mental disorders, wish to continue helping patients and colleagues, and rejection to use sick leave. Psychological need to deny or ignore, degradation of symptoms, previous traumatic experiences, history of mental disorders in family are some of the obstacles. Again, of course, team members have responsibility and it could be sometimes crucial to to be a good observer, and to approach friendly, supportively, and smooth to convince teammates for professional support, from whom his or her psychiatrist, if has one previously, or psychiatrist at the institution, via face-to-face, or in nowadays as is prohibited or is restricted telepsychiatry. Of course, other supports are also important in this case, and individual responsibility strategies and administrators' responsibilities is continuing. I try to say a few words on what can we do for ourselves and what can we do for our co-workers. But there are also other things that we can do at our institutions and what we can do as regional, national, or international organizations. I will show one example from my university, which is a series of short videos, 2 to 5 minutes videos. The background is all healthcare workers are very, very busy and tired. They do not have time and energy to read, so they often use smartphones. So why not give essential info in short with video? We organize many different short videos and were used frequently by working doctors like these titles: How to use breaks, recommendations to increase quality of sleep, work shifting and sleep, communication with COVID-19 patients, psychological stages after those, sharing information, continuing communication, etc. Another example that I'll give is social media campaign nationwide done by Psychiatric Association of Turkey. Again, short videos providing info on promoting mental health during pandemic, encouraging help seeking if needed, targeting general population, but also healthcare workers. By whom? By famous musicians, writers, and journalists, which was very effective campaign. Another example is for the nationwide organizations for healthcare workers is psychosocial support line, 7 days, 24 hours, organized by Psychiatric Association of Turkey, only for healthcare workers, by volunteer psychiatrists and child adolescent psychiatrists, with structured supervision by experts. Psychosocial support line mainly aims preventive mental health care, protecting caregivers from established mental health problems in the long run. Care for caregivers, disaster and trauma psychiatrists are familiar with this concept. So the idea of the 7 days, 24 hours is someone is there for me if I feel the need. Calls in Turkey range from simple concerns to suicidal thoughts, and rapid arrangements if serious mental disorder or risk happened were done. Not as busy as in the beginning, but still functioning, and high level satisfaction is still continuing. Overall evaluation will be published soon. I'm going to give one last example for international organizations. The COVID-19 Resource Center of the EPA, as Andrea mentioned, there are too many documents collected from all around Europe, especially from national psychiatric associations in many languages. Just to give an impression, Psychiatric Association of Turkey arranged about 30 different documents, and 3 or 4 of them translated into Arabic and Kurdish languages, which is the first time done in the history of the Psychiatric Association of Turkey. And it's important for the different populations. Coming to the end, Council of National Psychiatric Associations, we have 44 members from 40 countries, and the council consists of presidents and official representatives of member MPAs. Just a few examples of our activities during pandemic. We conducted a survey on the current situation. We also arranged webinar on challenges in psychiatric care and ethics during COVID-19 pandemic. And we are going to we dedicated the Interact, our official newsletter, to COVID-19 articles, which will be published in June. Also, we are planning a couple of different things. Just to conclude, well, the world, countries, and people have experienced unexpected disaster. We have learned numerous lessons, gained many experiences during the pandemic. Hopefully, this is true at all levels, individually, nationally, and globally, with many respects. However, pandemic has not ended yet. There is possibility for a second wave, maybe third or more. We need to be prepared. Many, maybe, economical consequences of the disasters will be with us for a relatively long time. And I believe that solidarity should be in the middle of our future perspectives. We should be ready for second and third waves of mental health needs for healthcare workers and for general population, especially on mentally and socially vulnerable and affected population, especially PTSD, complicated bereavement, depression, alcohol and substance use disorders, and others. My last word, preventive interventions are crucial today and will be crucial tomorrow. Thank you.
Thank you very much, Simavi. And thank you, Simavi and Andrea, both for keeping to time. So we have the opportunity quickly for a couple of questions. The first question I just want to deal with is several people have asked whether the presentations will be made available to participants. We will ask all the speakers for permission to share these and then hopefully be able to make these available online. The second question, which I would like to pick up from the Q's and A's, I think is a question for Andrea Fiorillo, which is, do we, if I understand the question correctly, is regarding whether we have any evidence or data looking at how healthcare workers have been affected in terms of their mental health compared to the rest of the population.
Thank you, Julian. Can you see me?
Yes.
Because I just can't see the last slide from Simavi's presentation. The question is about the situation of health professionals, right? Did I get it? Hello?
Hello. Sorry, could you just repeat that?
Yeah. Can you repeat the question? Okay, now I can see.
Okay, so the question was from the data that is available, and of course this is such a rapidly growing area of knowledge and experience, but from the data that's available, is there anything that looks at the difference between the effects on the mental health of healthcare workers compared to the rest of the population?
Okay, thank you. So I have here the data in front of me, and I mean, we have not analyzed yet, just rough data. And what I can tell you is that the levels of stress are basically the same for health professionals compared to the COVID plus, so more than the general, higher than the general population. That the level of anxiety actually is mean, while what is very high is depression. The general health questionnaire, meaning the general health of our health professionals, is just below the one of the patients with mental health problems. So they are suffering more than the COVID plus or the general population. And as regards obsessive compulsive symptoms, they have nothing. What is extremely interesting is about the burnout. I know that you are an expert in burnout, having led one of the most important international studies on that. What I can tell you is that these people feel high levels of exhaustion, and also of difficulties in feeling realized with their job. So they don't feel that they are doing a proper job. while the other dimension of the burnout, which is depersonalization, is very low. So it seems that the interventions should focus on exhaustion, personal exhaustion, mental exhaustion of professionals, and also on the importance of their work.
It's been suggested I should unmute, which I think is very helpful. Thank you. Thanks very much, Professor Fiorello. Professor Vahip, I wondered if you wanted to add anything to that?
Well, first of all, there is no clear-cut data, research-driven data, but with experiences, I can say that for a couple of months, 1 or 2 months, most of the people on their legs and working with their minds and with their bodies. But I am expecting something may happen after the pandemic or after the easing of the work. Some of the problems may start then, not now, probably.
Thank you very much. I don't see other questions at this stage, so I'm going to thank the first 2 speakers very much and hand back to my co-chair, Razvan, to introduce the next speakers. Thank you very much.
Thank you, Julian. Thank you for the previous speaker again from my side and my colleague's side. Now we will enter in the second part of this webinar, which we will see the trade union phase of what we face in this pandemic situation, how to support healthcare staff in managing stress and psychological risk connected with the COVID-19 pandemic, the role of the work in the trade union in the healthcare. So I'm glad now to invite my colleagues Kirsi Silampa from Tehu, Finland, to have a first presentation. Please, Kirsi. Unmute your microphone, left on the bottom. Unmute your microphone, left on the bottom. Okay, now. It's unmute microphone, but I think Kirsi it's logged with the name Lara Grosso. Could be a problem. The question is for technical staff. No, now it's unmute. But we didn't hear you, Kirsi. Do you have a problem? Okay. Okay.
Do you hear me?
Yes, please proceed.
Good afternoon for everyone. And I would love first, I want to thank you those presentations, which were very excellent. And it's very important to talk about these kind of issues and keep in mind those things you raised up when we are improving the healthcare system in the future. I'm Kirsi Sillanpää and I come from I come from Tehu. It's the Finnish Union of Health and Social Care Professionals. It's a very big union, and our members are nurses and matrons and ward nurses, mental health care nurses, and so on. And I'm working here in Tehu over 8 years as a director in field of development and social relations. But before that, I have very long experience from University Hospital in emergencies and there in clinical work, but also in leadership work. And I try to describe you all the situation in Finland, especially from nurses' view, and also how we have made cooperation to healthcare professionals, how do we support them reduce their stress. At first, I had to say that in Finland, the psychological strain or stress experienced by healthcare workers was already discussed before COVID-19 pandemic. The shortage of nurses and the ethical stress caused by their reduced possibilities of doing their work well have increased strongly. And this pandemic is further increasing the psychological strain of healthcare professionals by adding fear of getting infected, as you also have said, and of infecting others, and adding anxiety about how to take care of a colleague who might require intensive care unit, for example. In addition, psychological strain is growing due to increased responsibility to learn new clinical practices and to train staff from other departments as ECU nurses, for example. On the other hand, psychological strain is increasing due to fear that one doesn't know how to take care of new patient, for example. But what we have done in Finland this time, how to support healthcare personnel. In our Finnish hospitals, I had to say that occupational health and safety representatives and also human research units are committed to dealing with psychological strain. Instructions for supporting staff have been drawn up in collaboration between staff management and also occupational health and safety representativeness and also union representativeness. It's very important, and psychiatric experts. And we have threshold services we have been developed for employers, such as telephone service, where, for example, so-called work ability coordinators respond to employers' concerns and questions about psychological strain. Employers can be directly referred from the phone service to further treatment if necessary. Also, many psychiatric outpatient clinics have drawn up instructions for dealing with treating psychological strain, so that department heads knows where stressed employers can be referred to. And I had to say that it's important that the focus is on low threshold approaches. These can include conversation with professionals, referrals to occupational health care, and if necessary, referrals from there to psychologic or psychiatric. And the approaches such as moral support approach stress that we can be responsible for our own well-being and also that of our fellow workers. And then I had to say something about leadership, because healthcare personnel, especially nurses, they have been talking about where the leader must be in this kind of crisis. And the crisis, maybe I say so, that the crisis call for superiors and directors where the staff do their work. In other words, at the often invoked frontline. Now leaders are needed that reassure with their presence, speak clearly, encourage, calm, analyze the situation, are able to adapt objectives to change. And this makes high quality nursing possible, and even in a crisis. But leadership is not so often talking about these kind of things. I think that it's important. And maybe if there is something I can also answer, but these kind of things, maybe in Finland's situation, we are not in a very bad situation, and the figures of patients are going down all the time, and we can open the society better. But we wait what is going to happen. Thank you.
Thank you very much, Kirsi. We encourage our participants to use the bottom Q&A for the Q&A session, who are starting in about 20 minutes. For the next panelist, please, Andrea Filippi from FEPE CGL, Italy.
Good morning all. Luca, ci sei?
Yes, do you hear me?
Yes.
Perfect.
Ok, chiedo a Luca appunto di tradurmi, strada facendo.
I will translate Andrea while he's speaking in Italian.
Okay. I'm very sorry, but I don't speak very well English, so I prefer have a translator. Io, diciamo, nella mia attività professionale e sindacale, purtroppo per voi, purtroppo per gli uditori, mi occupo di due aspetti che sono il fulcro della discussione di oggi, ovvero io sono il segretario nazionale della funzione pubblica CGL Medici, ma purtroppo sono anche uno psichiatra. Vai Luca.
So in my professional activity, I'm dealing with two of the main aspects that we are discussing today. On one side, I'm the national coordinator of the trade union dealing with doctors of CGL, and on the other side, I'm also a psychiatrist.
E per questo, e per, diciamo, nell'andare incontro alle esigenze dei lavoratori, dei professionisti, degli operatori sanitari, la funzione pubblica CGL ha sentito fortissima l'esigenza di creare uno spazio, in questo caso digitale, denominato funzione protettiva, nel quale vengono coniugate appunto le esigenze sindacali, quindi con una risposta sindacale data ai lavoratori, con naturalmente le esigenze psicologiche degli operatori sanitari nell'emergenza pandemica.
For this reason, actually, my trade union, CGL, since the beginning of the pandemic, felt important and urgent the need of create a space that is called care function, playing also with the word of funzione pubblica, that is the name in Italian of the trade union, that is on one side putting together on one side our function as a trade union, so defending the right of our people and of doctors and healthcare, with also the psychological support that is in this moment of utmost needed.
Noi partiamo da un presupposto fondamentale che crediamo fermamente, anche in riferimento a quanto già hanno espresso chiaramente il dottor Fiorillo e il dottor Simavi, il professor Fiorillo e il professor Simavi, partiamo dal presupposto che non esiste pandemia o calamità naturale che possa essere causa di patologia psichiatrica in senso stretto. Vai Luca.
So we are starting from a point which has been already highlighted by the previous presentation by Dr. Fiorillo and Dr. Simavi, that there is any, let's say, psychological follow-up per se arising from a specific emergency or catastrophic event.
Psychiatric, not psychological.
Psychiatric.
Psychiatric, yeah. Al di là invece di un disagio psicologico che negli operatori sanitari viene reintrodotto nella cornice di quelli che sono tutte le sintomatologie dello stress lavoro correlato o del burnout, come prima ci spiegava sempre il professor Fiorillo.
But everything is, of course, but there is a mental distress exacerbated by the psychosocial risk and the stress, which is exacerbated during a pandemic.
Questi sintomi però si manifestano, queste sindromi, diciamo, strettamente legate alle professioni di aiuto in generale e alle professioni sanitarie in particolare, si manifestano laddove ci sono evidentemente degli elementi di vulnerabilità individuali, ma soprattutto collettivi.
There are, of course, those symptoms are mostly related to frontline workers and in particular healthcare workers, and they are built over an already existing either psychological problem or stress or organizational weaknesses that are already existing before the pandemic or the catastrophic event in the organization of the work of such frontline workers.
Ed è evidente, quindi, da questo pensiero ne deriva che sono fondamentali tutti i fattori protettivi che possono evitare l'emergenza di sintomi negli operatori sanitari. Questi fattori protettivi sono naturalmente, come dicevi tu, l'organizzazione, la socializzazione dei problemi, le risorse disponibili e naturalmente la valorizzazione dell'identità professionale degli operatori sanitari.
So it's fundamental in this framework that we try in particular to deal with what we call the protective factors. So what are the elements and the aspects that could support, let's say, and provide
Luca, non ti sentiamo. Luca, non ti sentiamo.
Luca, we lose you. We don't hear you.
Luca? I can try to phone him, so maybe.
Okay.
Do you hear me?
Yes.
Yeah, now yes. Bye, Luca.
Okay. No,
Sì.
I was saying that it's self-evident that we have a number of factors which are, let's say, that we consider fundamental to provide in order to provide support for the workers. Those factors are on one side the organization and on the other side the socialization and the evaluation of the function and the role of the worker in this particular moment.
E naturalmente la formazione professionale.
And of course the training of the worker, the professional training.
Ok, ora è di tutta evidenza che 30 anni di politiche neoliberiste hanno fortemente minato questi fattori protettivi nella misura in cui il taglio progressivo alle risorse, i progressivi cambiamenti organizzativi che hanno portato alla frammentazione dell'organizzazione, la progressiva dequalificazione o mortificazione della valorizzazione professionale e soprattutto la progressiva crescente denigrazione nei confronti degli operatori sanitari hanno chiaramente indebolito questi fattori protettivi.
So, of course, we are coming from 30 years of
No, Luca, non ti sentiamo. Luca, we don't listen you.
Do you hear me?
Yeah, now yes.
We are coming from 30 years of neoliberal policies which deeply dequalified the profession. And of course, this is building over a cut of resources, a dequalification of the workers, and on the other side, a fragmentation of their role. Building also on another factor which we need to take into consideration, that is the denigration and in general the worsening in the public opinion of the role of the doctors, general practitioner, and in general the healthcare functions.
Siamo fermamente convinti, peraltro, che l'idealizzazione a cui oggi vengono sottoposti gli operatori sanitari, che vengono inappropriatamente definiti degli eroi, è il frutto della denigrazione e la conseguenza della denigrazione di cui sono stati vittime per anni.
We also consider that this situation where workers, our frontline workers, healthcare workers are praised as heroes, this is on the other side the same coin of the de-evaluation and the denigration and the low public opinion view over those workers that we have seen in the last 15 years. Is the same coin side in another side of the same coin.
Bene, in questo contesto si inserisce l'iniziativa della funzione pubblica CGIL di creare uno sportello di ascolto psicologico a cui partecipano 50 professionisti volontari fra psicologi e psichiatri.
So in this context, we decided to create...
Luca, no? Attacca e stacca il microfono. Luca non si sente. Luca? Luca?
Sorry,
Yes.
sometimes his list is skipping the microphone. I'm saying in this context, we created a hotline and a desk of service where 50 professionals are working in order to provide support for professionals.
Esatto. E in questa esperienza noi ci troviamo di fronte alla situazione di dover rispondere alle problematiche sintomatologiche di ansia e di disagio fondamentalmente determinati appunto da problemi di mancanza, ad esempio, di presidi di protezione. Luca, ci sei? Quando è così, Luca, devi attaccare e staccare il microfono, secondo me.
Okay, do you hear me? So
Yeah.
we are in particular in this moment dealing with a number of the most important problems that we are facing, that workers are facing, that we are answering, providing answer, is on one side the lack of protective material. And Andrea, can you repeat, because I missed you for a second?
Sì, no, questa mancanza di presidi di protezione fondamentalmente produce l'ansia e la paura di diventare fonte di contagio per i cittadini, ma soprattutto per i propri familiari.
Of course, in this moment, this lack of protective material is also creating a lot of feelings of...
No, Luca. Attacca e stacca il microfono.
Being the springer of such a pandemic, so to be a multiplier of the contagion because they cannot protect themselves properly.
Così come ci troviamo di fronte ad una situazione spesso di assunzioni di responsabilità sproporzionate alle proprie mansioni che mettono i professionisti nella condizione di sentirsi particolarmente ansiosi di fronte alle prestazioni che devono condurre. Un esempio sono ad esempio gli operatori sociosanitari che nella gestione di RSA, cioè di residenze sanitarie assistite, si sono trovati nella situazione di avere amministratori magari malati e che hanno dovuto loro sostituirle in mansioni gestionali per i quali ovviamente non erano preparati.
Of course, this has led to a number, another problem that we are also facing is the disproportionate responsibility of workers and also of healthcare, in particular frontline workers, which has also to cover a number of duties that, due to the pandemic and emergency, they are asked to cover in order to deal with this. One example is in the healthcare workers in the social services sector, and in particular in the elderly care facilities, who has also to cover admin role and administrative task due to the pandemic, and they are also asked to refill people that maybe are sick and so on. And this is creating further stress.
Ma soprattutto l'elemento più frequente che abbiamo incontrato è legato alla mancanza di supporto, di sostegno, di vicinanza e di valorizzazione delle aziende sanitarie locali nei confronti dei professionisti veri protagonisti del contenimento della pandemia.
But the biggest problem we are facing every day.
Luca non si sente, attacca e stacca. Luca, we don't listen you, Luca.
By the organizations, by the hospitals, which are on one side lacking support, on the other side are lacking to support and also to provide, to evaluate also in this very moment the work that we are doing, that those workers are doing. So there is this lack of support, which is for us of utmost importance.
E quindi per il nostro esperimento, la nostra esperienza, e qui concludo, è legato naturalmente alla necessità tutta sindacale, oltre che naturalmente professionale, di creare supportare quei fattori protettivi, soprattutto collettivi, andando a rivalorizzare gli elementi culturali, dell'istruzione, sociali, relazionali e naturalmente legati alla salute, per rendere più forte, più resiliente, con una maggiore capacità di reazione la cittadinanza e naturalmente gli operatori sanitari.
Okay, so from here, our biggest priority.
Luca, non si sente.
To support workers by, in particular, giving value to the cultural, social, the training factors, which can improve the resilience of those workers, making sure also that they feel the support on one side, but also within themselves, the self-confidence needed.
Thank you very much.
Thank you very much, Andrea, for a very wide presentation of you. We have already 2 questions for the last part of this session, question and answer session. So I ask you to stay here with us and answer after the last but not least speaker, Claire Baker, please.
Can everybody see the
yes
presentation? Yeah. Okay. Hold on. Let me just. Okay. Thank you, everybody, for all those presentations. It's been really interesting, and thank you, EPSU and EPA, for inviting us on today. My name's Claire Baker. I'm an international officer for Unite the Union. We obviously cover a lot of the sectors across all industries in the UK, but we've got a very big health sector. And mental health is, through this crisis, is affecting all of our members, but we're seeing it most acutely in our frontline workers, in healthcare especially, but also across transport, bus drivers and local government. So today I'm just going to speak to you on what our healthcare members are telling us about the situation on the ground in regards to their mental health in the UK, and what the union is doing concretely to help support these workers. Unite, as I said, has around 100,000 workers in healthcare. Unison is the bigger union. It covers like nurses, etc. but we cover many of the support staff roles, the engineering maintenance roles, specific practitioners such as mental health, psychologists, physiotherapists, technician roles, as well as those in the community, health visitors, school nurses, and care home workers. Social care, many of who are employed on low wages by the private sector companies and are looking after the most vulnerable and the frailest in the care homes, are reporting that their employers have been unable to provide even basic PPE through this crisis. And it's a highly fragmented sector. It's got around 1,200 different organisations and companies providing the care system in England alone. So the mental health impact on these workers has been significant. What we're hearing from our reps in general across the whole of the health sector is the ceaseless work in the unfamiliar circumstances is taking its toll both mentally and physically on them. There is an undercurrent of unease and constant tension created in part from the workers' genuine fear of getting the virus itself, and in part from the working conditions, which, although they are improving, still could be a lot better. For our reps, there's a continuation of the general employment issues that they're still having to deal with, such as grievances and disciplinaries. So this is also adding to their levels of stress. Some of the organisations that Unite is dealing with are doing very well in engaging with the trade unions, but some are not. The membership themselves are very reliant on our reps, which is also a source of pressure for them. But running through this the whole time is the continued sense of pride that these workers have in the work that they're doing, and a sense of duty that they have. On the PPE and health and safety, now obviously that's been well documented through all countries. In the UK, the shambolic nature of how the government has dealt with it has been a source of anxiety. For example, the situation where they sent a plane to Turkey and it stayed in the airport for ages while they put in an order for PPE, and then it was the wrong PPE. The ventilator situation where they accidentally didn't see an email from the EU. All this has led to a lot of stress and anxiety for our membership. There's also a postcode lottery for PPE within our membership because of the fragmented nature that the government response has had. It's led to some local manufacturers making PPE, but then that's only to their local area. So it's left a lot of isolated services getting very little, or in some cases none at all, either from NHS, the central distribution, or any manufacturers in that area. We've got ambulance paramedics as our membership as well, and they are being affected not just by the PPE but also by the triaging. They feel under a lot of pressure of making the wrong call and being sanctioned for any mistakes that they make. They are not being given very good clear guidance on that triaging, on when patients should be taken to hospital. So we're seeing a very high level of anxiety amongst the paramedics, and also obviously a high number of deaths as well. The car park charging thing seems quite small, but it was at the beginning of the crisis, it was a point of friction with our membership. All of NHS staff were expected to pay between £50 to £200 a month to park their cars at hospitals in order to go to work, and obviously public transport was not an option during this crisis. So the union itself made sure that that the NHS hospitals took that need away, took away the fact that they had to pay for their car parking. Where the student retired nurses and NHS employees that are being brought in to help with the crisis are going through obviously the same levels of anxiety about their health, but also about what rights they have at work, what rights they have after the crisis is over, and what help will be provided for them on a mental health basis once the crisis is over. With BAEM, the Black and Ethnic Minority issue, this is one that's become very apparent in the last couple of weeks, especially, and our BAEM members have been coming to us with their own anxieties about the virus hitting them disproportionately to others. So as a union, we're calling for specific risk assessments to be made of our Black and ethnic minority workers in the NHS and on the front line. And also obviously for testing to be ramped up, which is woefully underdone in the UK at the moment. The whistleblowing situation, we found that a lot of people are under a lot of pressure not to raise any issues about any failings in the system, any problems with the PPE, because of we've seen that people have being penalised because they've raised any issues with the bosses. We obviously will be supporting any members that come forward to raise those issues and will help them through any kind of problems that they face because of that. Now, the union itself did a survey in the last couple of weeks it was on all of our membership, but had a very high proportion of healthcare workers that participated in it. And one of the main findings of that survey was this one, which was, in your capacity as a Unite rep, have you had to deal with an increase in the following during the crisis? And as you'll see here, the biggest issue that they're having to deal with is the mental health related issues. It's around 2/3 of the respondents reported to having to deal with the increase of mental health related issues. Now, another part of that survey said that was on the public service workers are undervalued for the work that they do and should be paid more. I just thought this might be of interest to people because it's really stark in showing that, you know, it's around 98% of people say that public workers are undervalued for what they do. And what is extremely concerning here, and is what is causing a high level of anxiety and stress amongst our membership, is that there was a leaked report last week that the government were going to actually put a pay freeze on all of our public servants in a way to economically deal with the fallout from the crisis. This is putting no end of problems on our frontline workers, who see it not only as a disaster for the health service in the UK, but also a huge insult on those who have put their lives at risk to help others, and is obviously contributing to the stress of them during this time. This one here is the privatisation of public services has made dealing with COVID-19 crisis more difficult. This is again quite an important thing. We think, you know, it's the NHS has been privatised, and it's being privatised through the back door. But because it's now quite fragmented, it has meant that they've not been able to deal with the crisis as well as they could have done. So the NHS itself, I just thought I'd show you what the NHS is doing itself for its workers. We've got the mental health support line for the staff, which came online on the 15th of April. It's run by the charity Samaritans, so they're very well versed in dealing with mental health issues, and is available daily, 7 days a week. And they're also offering help of a bereavement support line, for example, wellbeing apps for their workers, and virtual staff common rooms to keep that connection with people going. The union itself, we've done quite a lot of stuff for our health sector workers. We've been running Facebook Live events with our national officers that cover health and our lead professional officers. We've had weekly health sector digests, which is an email that goes out to all of our health sector members. and it will just give an update of the situation, an update of any new bits of advice, new bits of support that we can give to our health members. And that will be coming from the union itself, from the NHS, and also from the federations EPSU and PSI. And then we've been doing a few different mental health specific podcasts for our members, and that's led by our Mental Health Nurses Professional Association and the lead professional officer on mental health in Unite. And then they will invite professional speakers on there and to give advice, not just health advice, but in regards to the trauma, money, employment, etc., and what to do post-crisis. Unite as well has introduced a broader crisis helpline for all of its members and for vulnerable members if they need assistance during this crisis. And it will be for somebody to come and help pick up shopping, post mail, collect supplies, prescriptions, or even just to talk to somebody who is experiencing loneliness. And the postcard system is there where a volunteer will drop the postcard through the door of somebody who we think may be vulnerable or may be self-isolating, and it will give their name and contact details and what they can do to help them, so that there is that option there even if they don't want to use the helpline. We've produced a mental health guide for all the Unite members that will just give very basic and brief help on isolation from family and friends, short bits of advice on dealing with any kind of mental health issue that comes from that, advice on the diet, your diet to help maintain your well-being. And then it gives the World Health Organization mental health support principles and the NHS guidance, the 10 ways to improve your mental health, which is to stay connected, talk about your worries, support and help others, feel prepared, look after your body, stick to the facts and only go to credible sources for your facts, about your feelings, things to enjoy and what to focus on. So that's been sent around to all of our members, including all the healthcare workers. And then we've also got a more generalistic kind of advice for our members, which will just focus on their rights during COVID-19, about furloughing, about home working, about their own personal finance matters, and also more general stuff on the symptoms and health during the crisis. And just to finish up as well, I don't know if any of my trade union colleagues know of the Workers Uniting transnational union that Unite has with the United Steelworkers, which is from the US and Canada, and Los Mineros from Mexico. And we've been doing some work with them on the mental health of our healthcare workers post-crisis. And on International Workers' Day, we made the statement calling on all governments and legislators to ensure that there is sufficient accessible mental health and wellbeing provisions for all healthcare workers in the years to come after the crisis. And moving forward, I think that that's what us as a union and all unions are very well aware of and know that we've got to deal with, is the mental health of our healthcare and frontline workers. It's a huge concern and one that we will continue to help and support our members through. Thank you.
Thank you very much, Claire. Very nice presentation. We see a very nice overview about situation in UK. So now we go to the last part of this webinar of question and answer session. So we have 3 questions for Andrea. The first, I will read the question. I lose the first question. I will speak the second. From Simon Morse, from HOSPIM, our colleagues from Social Dialogue in European Commission. Could you please elaborate on the neoliberalism approach in regard to the role of doctors you were referring to? Okay.
Yes,
this is the first question, and I will read the second. It's the phone line dealing with all the professionals, porters, cleaners, health and care assistant. It's also dealing with the workers of care home and home cares. It's from Yolanda Gil from Spain, our colleagues from EPSU. Thank you for the moment. Waiting.
Ci sono.
Yes. Ok, allora per la prima domanda, che è molto interessante ed è il fondamento effettivamente di tutto il nostro lavoro e dello sportello, cioè gli operatori non si sentono supportati dalle aziende, dai professionisti e dai dirigenti che gestiscono le strutture. Quello che è la soluzione che noi sollecitiamo anche culturalmente come sindacato è quello di andare nella direzione di promuovere processi di responsabilizzazione, di partecipazione e di condivisione in un'organizzazione che sia polifunzionale e multiprofessionale.
So on one side, the first question is very interesting from our point. The main finding is that workers, healthcare workers, in particular those front lines, do not feel adequately supported by the management of our healthcare setting. So for us, the direction is only one, that is to invest in their responsabilization, to invest in their awareness, and qual era l'ultimo punto, Andrea?
Partecipazione e condivisione per una operazione, per un lavoro multiprofessionale.
So on one side, giving them responsibilities, on the other, giving them awareness, and let them participate, and also feeling like they are surrounded into a framework that allow multi-professional teams, and so that they can work also in this they can be protagonists of what they are doing.
Riferito invece alla seconda altrettanto interessante domanda sul neoliberismo, io mi riferivo al fatto che politiche neoliberiste nella salute hanno anteposto il valore commerciale della sanità e quindi della malattia a quello che invece è il valore economico della salute. Si è andati nella direzione di non prevenire più la malattia promuovendo la salute, per, come dire, incentivare il profitto che deriva dalla cura della malattia.
So when it comes to the question about neoliberalism, is also very interesting. I think that one of the biggest hiccups that we have seen in the past have been, in particular, the having given a commercial value and what we call a value for healthcare, for a value-based healthcare, which has put the profit beyond also the value of healthcare and also the economic value of healthcare, because we invested more than preventing the sicknesses and in general the problems, the public health program. We have put instead more investment into let's say healing and the symptoms, and when the sickness is already in place.
L'ultima domanda, sì, noi ci occupiamo di tutti gli operatori, e di tutte le strutture sanitarie, ma diciamo che noi accogliamo in realtà, essendo funzione protettiva della CGIL, tutte le richieste che hanno una connotazione di supporto.
So, of course, yes, to the question to Yolanda, yes, our hotline and in general our trade union covers all the different staff present in our hospital. And of course, we are also covering, we are called funzione protettiva in the sense that care function in the public service. And so we cover all the demands we are getting if they are relevant and if they need support.
Thank you.
Thank you very much, Andrea. We have one more question to Claire Baker. Something that could produce a lot of stress, it's having to do tasks that the person does not feel confident to do. How have the tasks that the nursing students have had to perform be organized? Have you been on the front line? Have they been from the front line? Sorry.
Unite with Unison and the Royal College of Nursing put an agreement together quite early on in regards to the student nurses that were being used within the crisis. The agreement was to protect them and to not let them go into any situation that they felt they weren't able to deal with. And it wasn't for the first year students, so it was more for like the experienced one, you know, the second, third year students. And that agreement said that they were entitled to supervision the whole time and work within a delegated framework and not rushed into anything to you know, to help with their own mental health and that kind of stress as well. So they're not put in any situation that they won't be able to deal with.
Thank you, Claire. I found another one from our colleagues from Fagforbundet. Anne-Marie, in your union, we also want to make a podcast with tips to worried health personnel. There, it's still a fine line between focus on mental health and an individualization that it is up to each person how well they cope the situation. We want to give tips, but not take a walk in the forest. You know what I mean. Has anyone from the previous speaker inputs to this?
I would say to use what we've done in Unite is to invite professional mental health people on there that know what they're talking about, set it up as a union, but have an actual professional to come on to give advice. And then that takes away that fear that you're walking in the forest.
Thank you very much, Claire. I don't know if it's technical possible to bring another question or from the direct live question from the participants. Maybe our colleagues from staff can help us if it's possible.
Yes, potentially it is possible. Just raise your hand in case, and my colleague Tuscany will provisionally promote you and let you speak in case. Just raise your hand. I don't know also on this, yes, so far there are no hands raised. We have still 10 minutes and I don't know if maybe also Dr. Simavi on the last question and Fiorillo wants to add something.
Well, I agree with Claire that there are different degrees of professional capacity or capability that can be provided. So in the general phone line, which serves on limited time, it's a kind of triage, or it's a kind of understanding what's the problem at first step. But then we can arrange a couple of future sessions with the applicant, or if the need is more severe or more deeply, like has previous traumatic events in his life, in her life, in that time, I think it's good to refer more structured psychotherapy. So there are different degrees of needs and different degrees of professional guidance, help, or support in this respect.
Thank you very much, Simavi. So I will ask if Julian can conclude and close this session from EPA side. Thank you very much. Please.
Okay, so thank you very much, Razvan. So I think one thing that has been really striking is the shared view from the different speakers in terms of the types of issues that we're dealing with and the kind of way forward and the tension that all of us are experiencing in different ways in our local areas between, on the one hand, the kind of government positions and the other hand, the health positions, and the very, very difficult situation which that places the healthcare workers. Or to put it a different way, many of the healthcare workers that I know seem to have this view that they very much appreciate the public praise, but what they really want is good working circumstances, good protective equipment, proper pay, sufficient staff, and so on. I'd like to say a huge thank you to all of the speakers. I'm going to start with Claire. So you've been promoted to the top now. Thank you very much for your contribution, and Kirsty and Andrea Filippi, and then also Simavi and Andrea Firillo. I think we've had a really nice view of different aspects of the really emerging issues, but also the shared understanding, the shared work to try and protect the mental health of healthcare workers. And it's been a great privilege for me to be part of this online discussion. I hope all the participants have enjoyed it. We will try and make sure that the presentations are posted online for people to access. So thank you very much to all from me. And the last, but obviously not least, I want to say a huge thank you to my co-chair, Razvan, and to all the staff who have worked behind the scenes to overcome my technical incompetence and make this successful. Thank you.
Thank you to Julian. Thank you to all the speakers. Thank you on behalf of my colleagues from EPSU. And as an end, we will send you all the greatness from my country. Have a good health and see each other health after this pandemic situation. All the best.
Thanks a lot.
Thank
we
you.
will post on the EPSU and EPA website the presentation, and we will let them circulate. So don't worry, you will receive the material. Thanks a lot and goodbye.
Thank you and bye-bye.
Bye. Bye-bye.
Thank you. Bye.
Thank you.